This is a brief presentation on how to present patients. This is geared towards learners in either their medical school or early residency training. This is the dumb EM doc. As always, I have no disclosures to report. This does not replace any physician's evaluation, and this only represents my views, not the views of my residency, my hospital, or any other group that I am affiliated with. So to break down presentations, it's kind of daunting, especially early in your career, because you don't really know what to say, and there seems to be kind of a lot of information, and you want to basically give it in the most efficient way possible. And so we use a mnemonic where we talk about presentations. It's called the SOAP mnemonic. Basically, we start with the subjective portion, we move on to the objective portion, and then we get to an assessment and plan. And basically, all of your presentations, whether it be to a resident, whether it be to an attending, whether it be to another consulting group, you're going to be giving these very short presentations to very long-winded presentations when you get into the ICU. And so it's important for us to use the medical terminology that we used and learned in medical school, and basically be able to communicate with one another. And so the subjective portion is kind of basically your time to show that you did a proper kind of history. We always start with the chief complaint. Why did the patient arrive in the emergency department or their primary care doctor's office? What are they complaining about? And this doesn't mean what they're complaining about the loudest. Usually what it means is, let's say they come in, and they're talking about their shortness of breath, but they also have chest pain and they're nauseous and they're vomiting and they're clutching their chest and they're diaphoretic. I would say you could say the chief complaint for that is either shortness of breath or chest pain, but it's important for you to realize that some of those things are kind of associated with one another, and you can talk about that with your kind of pertinent positives and pertinent negatives. And so you can talk about your HPI. It should be very brief, and then include your pertinent positives and negatives throughout. As always, when you're kind of giving your one-liner, you want to talk about pertinent medical problems, or if this is something that has to do with the surgical, whether it be abdominal pain or post-op day, talk about their surgical history. If there are any relevant medications or allergies or family history and social history in that kind of chunk, this is where you would want to put it. That doesn't mean every time that you get the history that all of these things are going to be important. For instance, to go back to the patient who has chest pain and shortness of breath, it would be important to note their age, their gender. Do they have things that are associated with chest pain, such as high blood pressure or diabetes? Or let's say they have a family history of somebody who their brother passed away when they were in their 30s, or so on and so forth. In terms of their social history, are they using drugs? That kind of stuff, and so not every sort of kind of complaint are you going to need to do a complete history and physical, but at the very least, even if you did the complete history and physical, only include the things that are pertinent positive for that, specific chief complaint. And then kind of as we go along and, let's say you're not in the emergency department anymore and you're in, kind of the internal medicine or surgical ward, basically your subjective portion becomes what happened overnight, or what did the patient complain of this morning? And then, basically that's where they get to kind of interject and say, I'm having pain, or I now have this new complaint. And then every sort of time you don't have to go through the complete history and physical, but just do the things that are kind of relevant for their hospital stay. The next section is the objective portion. And so, to me, really the most important thing that discerns us and our clinical training is whether or not the patient looks sick or not. And there's a lot of patients who are sick that kind of look like they're healthy or normal and stuff like that. And so this is something that comes with time, something that comes with some gray hairs, but basically the ability to tell a patient sick or not sick. Because if you're sick, then there's a much kind of different algorithm that you're going to take with these patients than if a patient is kind of not sick and you have a lot of time to do kind of tests and things like that. And to help kind of assist you, you should look at their vital signs. And so there's always 5 vital signs that we care about. So temperature is kind of the first one there. Heart rate, blood pressure, respiratory rate, oxygen saturation. Sometimes people throw in glucose here as well, but that's not always something that you're going to obtain with every patient. Again, make sure that you include the physical examination. Here, only, focused and again, pertinent things are really the things that you care about. For instance, somebody who has chest pain, heart and lung are much more important. Did you listen to their carotids for Bruy or something like that? Do they have JVD? Did you look at their extremities and do they have edema? That kind of stuff. Whereas, I would still do the abdominal examination, but maybe you don't need to go through listening for breath, saying that you listen for breath sounds and all of those other things, because it's just not as pertinent to your complaint. If you have labs, here's kind of where you can add them to your presentation. Usually when we're in the emergency department, we don't have labs unless the patient had labs that day or that week. But this is kind of more relevant when you're presenting in the wards or presenting in the ICU. Same thing with micro, some things that we may or may not have. And then again, imaging. All of those things are, let's say you got them overnight, or you're going to get, rather than when you're in the emergency department, you may not have access to all of these things unless they already saw a primary care doctor and had a kind of basic workup. This is where you can kind of put all of that back in. And then really the most important part of your presentation is your assessment. And so this is really the meat. This is where we get to see your critical thinking. This is why you went to medical school. Anybody can do the subjective and objective portion. That's basically reporting. It is an art to do a, pertinent, complete history and physical, but this is really where you get to shine. And so there's kind of 2 ways to do this. You can do problem-based or systems-based. If you're in the emergency department, you're going to probably do problem-based. If you're in the ICU or you're in a medical ward, sometimes you'll do more systems-based, where you'll go system by system and talk about the neurosystem and the cardiovascular system and respiratory, and that's just to make sure that you're more complete and don't miss anything. That's not to mean that you don't do that kind of in your mind in the emergency department, but if somebody's coming in with chest pain and they're awake and alert, it's much easier to kind of just focus in on that and hone in on kind of the life threats for that, rather than kind of going systematically about their musculoskeletal and their skin at that point. You still look at their skin, but you don't have to kind of talk about that in the assessment plan. And so basically I start again with my chief complaint. So this is a 40-year-old male, past medical history of hypertension, diabetes, presenting with chest pain. They have no history of any kind of coronary cath or echocardiogram. And I'm concerned about, and then this is where you say what your life threats are. And so are they having an MI? Are they having, you could basically kind of incorporate all of ACS into your one complaint. And then there's kind of other things that we talk about, things like PE, aortic dissection, et cetera. But just make sure that any chief complaint, no matter how small, it's important, especially in the emergency department, to think about what is the badness that could happen. If you have an extremity fracture, it's probably just a broken bone, yeah? Or a bone bruise or whatever, probably musculoskeletal. But don't forget about the things like compartment syndrome or kind of anything that could have nerve damage, or it's very easy to anchor on something, and a lot of badness presents as something benign to start with. And so if you keep your differential broad, it's much harder to get kind of burned by the patient or burned by the kind of presentation, because you thought about it. You want it to kind of rule in or rule out the other things with tests, or sometimes you just have to do it with your history and physical. And so after you get to your assessment and you've included your differential diagnosis, you want to get to the plan. And so what labs, imaging, tests are you going to need to rule in or rule out patient's diagnosis? And then there's kind of 2 things that I do here. I break it down into what I do for the patient. So do they need fluids? Do they need something for pain, nausea? Even something as small as a blanket or a cup of water if you don't think that they're going to need surgery. Whereas there's other things that you do for yourself as the doctor. And a lot of those things are you get a CBC or a BMP or a troponin, an EKG, chest x-ray, those types of things if they're talking about chest pain. But just make sure that when you do order those tests that you actually kind of think through what you're ordering. And I'll talk about that kind of in my next presentation. But just to kind of sum everything up, again, when we're presenting patients, we do it in kind of a systematic manner. So SOAP is subjective, objective, assessment, and plan. And just make sure that every time you do it, you're going to get a little bit better. Anyways, this is the Dumb EM Doc signing off. Let me know if you guys have any questions.